this video, we are going to discuss about Achalasia Cardia. Achalasia is a primary esophageal motility disorder characterized by the absence of esophageal peristalsis and impaired relaxation of the lower esophageal sphincter in response to swallowing. This is your intestinal tract and it's functionally divided into segments by muscle rings known as sphincters, and they restrict the flow of intestinal contents to optimize the digestion and absorption. These sphincters include the upper and lower esophageal sphincters, the pylorus in the stomach, the ileocecal valve in the large intestine, and the inner and outer anal sphincters. The intestine is composed of four major functional layers: the mucosa, submucosa, muscularis propria, and serosa. And in between these muscle layers, we'll have the two major networks of nerve fibers of the gastrointestinal tract. That is the myenteric plexus and the submucosal plexus. The myenteric plexus is also known as the Albach plexus and it's located in between the outer longitudinal and the middle circular muscle layers. The submucosal plexus is also known as the Meissner's plexus and it's located in between the middle circular layer and the mucosa. Together, these neurons will form the enteric nervous system. When you eat, the food is mixed with saliva in the mouth and it is propelled into the esophagus, and with the help of peristaltic waves in the esophagus, it will move the food into the stomach. So as a response to this local stretch initiated by the food bolus, a circular contraction occurs behind the food bolus and an area of relaxation occurs in front of the food bolus. So the food is propelled in the forward direction. So that's how this food bolus is going to travel from your mouth to the stomach. But before the food bolus enter into the stomach, we have the lower esophageal sphincter. Unlike the rest of the esophagus, the musculature of the lower esophageal sphincter is tonically active, but it relaxes on swallowing. So because of this lower esophageal sphincter, gastric contents won't be refluxed back into the esophagus in between your meals. This lower esophageal sphincter is made up of three components. That is the esophageal smooth muscles, which will form the intrinsic sphincter, fibers of the crural portion of the diaphragm, which forms the extrinsic sphincter because it surrounds the esophagus, and finally the oblique or sling fibers of the stomach wall, which helps to create a flap valve and helps to close off the esophageal junction and prevents regurgitation when intragastric pressure is increasing. The normal tone of the lower esophageal sphincter is under a neural control. The intrinsic sphincter function is controlled by the vagus nerve and the extrinsic sphincter function is controlled by the phrenic nerve. So when there's a release of acetylcholine from vagal endings, the intrinsic sphincter will contract and there's a release of nitric oxide and VIP, which will cause the intrinsic sphincter to relax. Contraction of the crural portion of the diaphragm is coordinated with respiration and the contractions of the chest and abdominal muscles. So the intrinsic and extrinsic sphincters will operate together to permit the perfect flow of food into the stomach and prevents reflux of gastric contents into the esophagus. In Achalasia Cardia, this occurs due to a lower esophageal sphincter failing to relax. This could be due to a selective loss of inhibitory neurons and ganglion cells in the myenteric plexus or due to a deficiency in the esophageal peristalsis. When the lower esophageal sphincter doesn't relax, food can get stuck and get accumulated at the lower esophageal junction and the esophagus can become massively dilated. So the patients can present with regurgitation and dysphagia. In here, the dysphagia is for both solids and liquids, and it's an important factor to know in contrast to esophageal carcinoma where the dysphagia is mainly for solids, but in achalasia it's for both solids and liquids. The incidence of achalasia is 1 in 100,000 and it's equal in males and females. It occurs at all ages, but it's rare in childhood. The patients will typically present with a triad of incomplete lower esophageal sphincter relaxation, increased lower esophageal tone, and esophageal aperistalsis. And these patients usually have a long history of intermittent dysphagia, characteristically for both liquids and solids. The regurgitation of food can occur at night, and aspiration pneumonia can also occur as a complication. Loss of weight can also occur, but it's quite insignificant. The etiology of Achalasia Cardia can be divided into primary and secondary causes. The primary causes are due to the failure of distal esophageal inhibitory neurons or due to idiopathic causes. The secondary causes are due to infections like Chagas disease. In here, the Treponema cruzi infection will destroy the myenteric plexus. Autonomic neuropathy in patients with diabetes, infiltrative diseases like malignancy, amyloidosis and sarcoidosis, and lesions in the dorsal motor nuclei like polio. So how do we investigate this condition? On a chest X-ray, because of the food accumulation in the gastroesophageal junction, we can see a massively dilated esophagus. Sometimes a fluid level can be seen behind the heart, and the fundal gas shadow is absent. When we do a barium swallow, it shows lack of peristalsis and synchronous contractions in the body of the stomach and esophageal dilation. The lower end of the esophagus shows a classic bird's beak appearance due to the failure of the sphincter to relax. So whenever there is a recurrent and continuous accumulation of food, it can irritate the lumen and lead to esophageal cancer later in life. So we can perform a esophagogastroduodenoscopy and CT scan to exclude a carcinoma at the lower end of the esophagus, as this can produce similar X-ray appearance. Esophageal manometry is the confirmatory investigation, and it shows aperistalsis of the esophagus and failure of relaxation of the lower esophageal sphincter. Treatment of achalasia is mostly palliative. It can be treated by pneumatic dilation of the sphincter, where they use a pneumatic balloon under X-ray control to weaken the sphincter, and it's initially successful in 80% of the cases. Another treatment approach is botulinum toxin. Inhibition of acetylcholine release by injecting the botulinum toxin into the lower esophageal sphincter is effective and produces relief which lasts for several months. For a transient release of symptoms, we can use calcium channel blockers like nifedipine. Surgical treatment of choice is the surgical myotomy, which is also known as the Heller's cardiomyotomy. This can be done either by laparoscopically or laparotomy. There's also a new technique called per-oral endoscopic myotomy or POEM, where they will divide the lower esophageal sphincter using a gastroscope. I hope you guys learned something today, and you can support my channel by simply clicking the like button, commenting and subscribing. I'll see you again next week with another interesting topic just like this. Until then, goodbye.